Let's start this way, Dr. Laird. I heard your message on your machine. You don't take any new patients. You got no room.
We don't, that's true. Since this anti-opioid law went into effect in January, there are, I think, thousands of patients left without a pain physician. And so we've been inundated with calls and faxes of family doctors trying to refer their patients. And I took as many as I can, but at this point I only take a new patient if someone leaves the clinic or they complete their therapy.
Do they, the powers that be, do they look at you how many, and is there a threshold of how much you could prescribe overall, how many, based on how many patients you have, or do they even tell doctors about that?
You get the sense that there are guidelines and that doctors are being monitored somehow, but we're not ever given, as far as I know, given any specific limits or triggers as to what causes increased scrutiny of your practice.
I mean, that's what scares doctors. Without a specific guideline, you don't know when you've crossed the line into some area that can get you in trouble.
Oh, absolutely. There are physicians who think that if they go on a news program and talk to George Knapp, that the DA is going to come crash through their door the next day, and perhaps that's true. I hope not. But yes, doctors are afraid. They're scared of what could happen, what's going to happen. Are they going to lose their practice? Are they going to lose their livelihood? Will their patients suddenly be abandoned? Those are big concerns.
A lot of them have been abandoned.
And they have, absolutely. There are at least hundreds, perhaps thousands of patients whose doctor has said, I'm sorry, I can't prescribe opiates anymore. You're going to have to find someone else. And there just isn't anybody.
And these are people who have played by the rules, who are not overdosing. They're doing what their doctor says, taking the medication as prescribed. They are in legitimate pain, and they just say, sorry.
Absolutely, Mr. Knapp. If patients in a pain clinic like mine, if they're appropriately screened and we're treating legitimate pain issues and we're playing by the rules, certainly less than 5% and probably less than 1% of the patients are going to develop an addiction problem. Of course, it's the physician's responsibility to look for the signs and symptoms of addiction every visit, every month, and to immediately deal with that when it occurs. But it does occur with very low frequency, and those people tend to declare themselves pretty quickly. Within 2 or 3 months, you have a good idea if someone's getting into trouble.
Opiates, opioids, I mean, they are strong. Even prescribed properly, they're strong medicine. There are always going to be risks, as with any kind of medical care.
Absolutely. They are dangerous drugs. They're like automobiles. They can do harm. They can do great injury to people, but they are necessary in our culture. There are people who need them. They should be available to patients who need them, and they should be safely prescribed.
And for whom they work. And for some patients, it's what works. It's what works best, and maybe there's no alternative.
Absolutely. We never jump to opioids as the first line of therapy. We always try, in our clinic, the physical modalities first. We're going to try ice, heat, massage, and physical therapy is probably the mainstay of our pain clinic. And if those things don't work, then we'll try adding a non-opioid medication, usually a non-steroidal anti-inflammatory drug like naproxen, sodium, or ibuprofen, or meloxicam, or something like that. However, there's a lot of people who can't take those types of drugs. If you have sickle cell disease with painful crises, you have to be very careful about the amount of ibuprofen you take because it can injure your kidneys. If you have stomach ulcers or bleeding esophagitis or something like that, you may not be able to take an NSAID. And for the elderly who are particularly prone to gastrointestinal problems and kidney problems, opioids, sometimes a very low dose of opioid, is the only option for somebody with like end-stage rheumatoid arthritis or something like that.
End-stage cancer. I mean, we're hearing stories now in hospices that they can't get access to opioids to ease the pain of people who are dying. And the reason is this big crackdown, and now they're talking about cutting the overall supply even further.
Absolutely, and I think it's a combination of doctors and nurses are afraid to prescribe, nurse practitioners, physician assistants, physicians are afraid to prescribe is one part of it, but the other part of it is they've created such a circus of paperwork and I've heard friends of mine who are ER doctors say, good night, it's just not worth filling out so many forms and writing all this justification and trying to get all of their previous medical history for their entire life, making a good faith effort to get all of their medical records to prescribe a week's worth of Vicodin for an ankle sprain. People just say, I'm throwing in the towel, it's just not worth it.
Pharmacies say that too?
Oh, absolutely. And the pharmacists are put in a difficult position. They're getting pressure. And then they, in turn, some of them in a misguided fashion will harass the patients. This law has created an environment where the pharmacist looks at the patient and makes some kind of a determination as to whether their pain is important. And unfortunately, it's not always based on their medical history because they don't have access to their full diagnostic imaging and laboratory studies, so they tend to some of them make a determination on what are probably unlawful criteria, like I don't like the way you're dressed, or I don't like your skin color, or the way you're behaving, or your insurance, your Medicaid, and you probably don't even have a job anyway, so I'm not going to fill your opioid prescription.
Profiling.
Absolutely, yes. And it's probably unlawful. This is an area that needs to be developed further as to whether these pharmacies that deny public accommodation, in other words, they deny service for reasons that are not valid, is that a violation of the American with Disabilities Act when they perceive the patient as having an opioid use disorder or substance use disorder when they really don't? In other words, if someone perceives you as being disabled and you're not, that itself is a violation of the ADA.
Put on your attorney hat for a second.
Yes.
Is there a case to be made along those lines? I mean, I'm surprised there isn't some legal action or pushback from pain patients across the country who are desperate. Some way to strike back and balance the scales a little bit.
Mr. Knapp, I believe that is the case. I believe that there are legal arguments to be made that denying public access to pain patients based on a incorrect perception that they have a substance use disorder is a violation of the Americans with Disabilities Act. And I do know some attorneys who are working on that. It's not my area of expertise, but I do feel that there is unlawful discrimination. And I think that's going to play out in terms of patients are beginning to stand up for their rights. And I have to tell you, it's largely because of the movement that you started with your series, and that has had a national impact. And these patients are changing the game by standing up for their rights.
You know, every day in our line of work, we write stories. People in my line of work write stories about the opioid crisis. Still use that term. And we quote elected officials from the president and the governor on down who all say basically the same thing. And you know that it's not true, that they're talking about, they say opioids and the public hears pain medication. Those numbers that you've got, those statistics from 2017, 2018, I mean, you've had a couple of minutes to look at it. What did they tell you? What jumps out at you?
Well, George, this information that I guess your team has been able to obtain is a game changer, because what it does is it confirms every suspicion I have had and other doctors have had about the dishonesty that's associated with this, with the publicity that surrounds this purported crisis. And what this data shows very clearly is that most of these deaths, in fact, I would say, just eyeballing it quickly, that the vast majority of these deaths don't involve a single prescribed opiate. They involve polypharmacy. In other words, the patient who died has been taking a number of medications which have a sedative effect, and it's the combined effect of 3, 4, 5, sometimes 6 drugs that cause their death, only one of which was an opiate. And I would also point out that when it is an opiate, it isn't clear from this data, they don't distinguish whether that's an opiate that was prescribed by their physician, or they stole from someone else, or they borrowed from a neighbor. So it really brings into question the statistics that have been used to justify this war or crackdown on chronic pain patients.
I mean, addicts taking cocaine, methamphetamine, and maybe there's an opioid in there somewhere from some various source, licit or illicit, that gets mixed in, but it's all called opioid deaths.
Absolutely, and some of your viewers may not know that a commonly abused drug, heroin, is diacetylmorphine, It's just the morphine molecule with a couple of extra branches on it that makes it cross the blood-brain barrier much more quickly, and it gives an immediate high when it's injected intravenously. It's an opioid, and it's counted on here as an opioid. So all the heroin deaths count as opioids from the governor's standpoint. So when the governor says that in 2017 there were 388 opioid deaths, some of those are heroin deaths. So you really have to get down and look at the nitty gritty, which fortunately you've brought out, to see what's really going on.
I mean, some of them are heroin deaths. Some of them look like they're drownings, heart attacks, and they had various drugs in their systems. They all get called opioid deaths.
Yes, it appears, just looking at this and making a very preliminary assessment, that if the toxicology showed an opioid in their system at the time of their death, that it's counted as an opioid death, which is quite misleading.
Some of these people could be legitimate pain patients who made a mistake. Some of them could be legitimate pain patients who took their own lives because they weren't going to get any more medication or stole the medication from somebody else, as you mentioned. But the mistakes can happen with this kind of medication. I guess what is not factored into any of this is that the counterbalancing value to the patients who benefit from it. There is risk, but there are a lot of people who benefit from it for whom the risk is worth it.
Right, and that's certainly something that has not been brought out. The news stories tend to focus on people who died as a result of misuse or abuse of the medication, or people who developed problems with addiction, not on the 99% of people who safely take opioids, who have an improved quality of life, and who actually abide by the law, don't have addiction, and derive benefit from their medication. And there are thousands of people like that in Nevada. The people who have brought us this law are very fond of pointing out that 1 person a day dies of an opioid overdose in Nevada on average. It's maybe a little bit more than that, 1.1. That's less than it was in 2011. It's gone down every year. It's gone down 30% over the last several years. However, 17 people a day in Nevada die of heart disease. 14 people a day die of cancer. 4 people a day die in Nevada of lung cancer every day. So it's important to keep these things in perspective. 1 person a day dies in Nevada of an opioid overdose, but that includes everybody on this list. That includes everybody who had an opioid in their system at the time of their death.
What it doesn't include is tens of thousands of people who've been able to take it and for whom it makes a great deal of difference in their quality of life.
Exactly, and those people are becoming much more vocal, and they're beginning to stand up for their rights.
One last question. You know, in our business, we're told to follow the money. Where does follow the money lead us in this? In what's driving this train? We read these stories at the national level of billions of dollars being set aside for addiction, as if this is all about addiction.
Well, I think that you're on the right track there. I think that for whatever reason, this is a complex problem with lots of facets, and there's a lot of stakeholders and there's a lot of people who have an agenda in this business. But one of the very prominent and vocal parts of it is the addiction medicine industry, which is a combination of rehab centers, and it's also a combination of big pharma. In other words, the manufacturers of buprenorphine and other opiates that are agonists, that are used to treat this new disease that came out a few years ago called opioid use disorder. And if you watch the literature, there seems to be an increasing blurring of the distinction between addiction and dependence. And it's a very important distinction that's always been made in medicine, but there is pressure, subtle pressure on physicians to diagnose patients with opioid use disorder and get them on buprenorphine, which is very expensive, requires either an injection monthly or a prescription of medication monthly. So it's not all altruistic in terms of people concerned about the so-called opioid crisis. There's vested financial interests that are having an effect.
So the big drug companies that led us down this road, at least part of the way in the beginning, have found a way to bounce back.
I think they're playing us on both ends. I do.